هيكون في اختيارات، وانت ممكن تختار من الأسئلة زي ما بيجيلك في الامتحان، وبعدين أنا هعقب بعد كده على الاختيارات. الحالة الأولانية طبعا هتكلم بالإنجليزي عشان الناس تعرف تستفيد. And this is the first case where the patient is in the intensive care unit, and this chest X-ray showed opacification of the left hemithorax and clear right hemithorax. Then the diagnostic possibilities include left lung hypoplasia, left lung consolidation collapse, right sided tension pneumothorax, أو mal-rotated chest X-ray.
B. Yes.
Yes, this is the left lung consolidation collapse. What is the cause?
Right-sided endotracheal tube.
Yes, very
Malposition endotracheal.
malposition of the endotracheal tube, which is placed more down than usual. It has passed the carina into the right main stem bronchus, so the bronchus of the left lung is occluded and the right lung is only aerated. And this is one of the ABCs whenever you are interpreting a chest X-ray in the intensive care unit and you see an abnormality in the lung. It is very important and very essential to look for the tubes, because of the malposition and the inaccurate position will result in so many complications, as I have mentioned before. Then the endotracheal tube best location is about 5 centimeters above the carina, and you consider that the endotracheal tube will go down by 2 centimeters with flexion of the neck and go up 2 centimeters with extension of the neck. And the position of the endotracheal tube frequently is passed into the right main stem bronchus, which will result in obliteration of the left main stem bronchus and the aeration of the right lung only. If the endotracheal tube is pushed more than this, it will also obstruct the right upper lobe bronchus. I didn't understand. Okay. We'll continue this. Okay. Then
يا ريت يا جماعه اللي حوالين ده بس يبقى يعمل ميوت. شكرا.
And this is another example of the endotracheal tube in a lower down position passing into the right main stem bronchus, causing similar appearance. Then the second case is a patient with multiple pulmonary nodules on the right side, and maybe also there is some nodules on the left side. Then what do you think of this septic emboli, lung
the pleural deposits.
Deposits, lung and the pleural deposits?
Yes.
Okay.
Yes.
Based on what?
Mastectomy.
Yes, very good. There is absence of the left breast shadow, and this is an indication of mastectomy, which is commonly performed for breast carcinoma. Then you can see multiple lesions in the right lung and maybe in the left lung as well, and this is diagnostic of metastasis. Mastectomy is one of the common presentations in the exam, where the examiner depends on your attention to the absence of the shadow of the breast. Then you consider the history of the patient. And whenever I projected this case before, for some of the chest physicians. They said to me, what is the history? I said, the history is in the film. Then the history is in the film, and you know that the absence of the breast shadow is an indication of breast cancer. The next case is a patient with a chest pain, dyspnea, cough, and mild fever. And these are the possibilities: TB, cavitating pneumonia, sarcoid, idiopathic interstitial fibrosis.
B.
This one.
Sarcoidosis.
Cavitating pneumonia or sarcoidosis.
Sarcoidosis.
Okay.
Not sure.
Reticular upper distribution.
Then I intentionally projected this case because we are now do not taking TB into our consideration. I don't know why, but in the past days where they consider every abnormality in the chest X-ray to represent tuberculosis until proved otherwise. And they taught us that the TB usually affects the upper lobes and it results in reticulonodular infiltrations as well as cavities, which represent chronic abscesses. Then cavitating pneumonia is not a right diagnosis, and also sarcoid needs to have some of the lymph nodes, and the sarcoid do not produce cavities in the lung. Then you should remember that post-primary tuberculosis will present by reticulonodular infiltrations in the upper lobes or in the superior segments of the lower lobes. And these nodules may vary in size, and they are usually big in patients who are immune compromised. Then the appearance like this is a stimulus for the diagnosis of TB whenever you see an infiltration in one of the upper lobes or both of the upper lobes, especially if you can see cavities and also if you see some calcium. Then the following case is,
دكتور عفوا chest X-ray there is a cavity in the right apical zone.
yes, all there are bilateral cavities. This is a big one, and this is a smaller one, and another one here. Okay.
تمام تمام شكرا.
Okay, this is a female patient, 50 years old, with productive cough, sore throat for 1 week, no fever or chest pain. Then what do you think of this?
COVID-19.
Yes.
COVID-19.
Okay, good. This is right. And this is COVID-19 with the classic appearance of ground glass opacities, which are scattered in
Peripheral.
both lung fields, especially in the periphery. And you remember that the ground glass opacities in the lecture of diffuse lung disease are classified into two types, the acute type and the chronic one. The acute type, the differential diagnosis is pulmonary edema, whether it is cardiogenic or acute respiratory distress syndrome. The pneumonias, especially the viral pneumonia and the pneumocystis jirovecii, which is the pneumonia occurring in AIDS patients. Also pulmonary hemorrhage and acute eosinophilic pneumonia. But these are the recent RISNA guidelines for the COVID-19. Actually, there are 4 categories standardized for reporting of the COVID-19. They include the typical appearance, the indeterminate appearance, the atypical appearance, and the normal finding, which is negative for COVID-19 pneumonia. Then this is considered the typical appearance, where you see ground glass patches peripherally located more towards the lung bases. And this is what we call indeterminate appearance, where you got only one patch of ground glass opacity, and you need further evaluation by the PCR test or other laboratory test to confirm the possibility of COVID-19. The atypical appearance is what are you looking for, which is some of the haziness in the lung fields, and you do not go see actual ground glass patches or peripheral distribution. Then this is known as atypical appearance, and it should be reported in the radiology report as the viral pneumonia. And you recommended the help of laboratory tests to confirm the diagnosis. Then, if you see typical and indeterminate features, consider COVID-19 and take all the measures for this. And a considerable number of cases with PCR positive for COVID-19 are classified in the category of atypical or negative pneumonia. You know that there are patients with PCR positive and negative CT chest. Incidental findings do not necessarily need to be reported as COVID-19, and you may only you just say that this is viral pneumonia until you are sure about the diagnosis, considering the laboratory findings, of course. This is one of the recommendations also, which do not recommend the use of any of the reported predilection models, which are frequently written in the reports as CoRAD 5, CoRAD 7, and so on. But these are, according to the RSNA, are poorly reported, and they are at high risk of bias, and their reported performance is probably optimistic and is not a real finding. Then what is the behavior if a patient had symptoms suggestive of COVID-19 infection, which include fever, cough, shortness of breath, fatigue, and sputum? There are two options. Either you go first for laboratory investigation or you go for CT. Then you perform CT in all cases for two reasons. Number one, it may help in the diagnosis. Number two, it is used as a baseline if complications happen to the patient. Then who are subjected for complications, or what are the risk factors for progression? The old age and the presence of comorbidities like cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and immune compromised status. What are the most dangerous complications? Number one, acute respiratory distress, pulmonary embolism, superimposed bacterial infection, and acute myocardial injury. Then the next case is a patient 55 years old with left shoulder and neck pain.
D.
Yeah,
Bronchus tumor.
Bronchogenic carcinoma.
tumor. And which is of these possibilities?
D.
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 This is
Bronchogenic carcinoma.
yes.
D.
This is
Bronchogenic carcinoma.
okay, and this is bronchogenic carcinoma, which is located at the apex of the chest and
Yep.
is known as Bankus tumor or the superior sulcus neoplasm. If you diagnose this lesion, it would be better to go direct for MRI, and the CT is not usually helpful in these cases. It will show the same finding as the chest X-ray, a mass with rib destruction. But you need some informations for surgery. This tumor can be operable and cannot be operable. When it is non-operable, when it invades one of three. the brachial plexus nerve roots, the subclavian artery, or the subclavian vein. And these three structures cannot be evaluated by CT. Then in cases of Bankus tumor, you need the help of MRI, especially the sagittal image, where you can see the roots of the brachial plexus, the subclavian artery, and the subclavian vein, and you decide the relation of the tumor to these important structures. Any invasion of one of these three structures is a contraindication for surgery. Then X-ray can help in the diagnosis of the tumor by notification of the adjacent rib destruction, but you need MRI for the three structures, important structures I have mentioned. Then this is an 18 years old male with a car accident. And this is the chest X-ray, and after 2 days, this is the chest X-ray.
Pulmonary contusion.
D. Fusion C.
Okay.
C.
Aspiration pneumonia, E.
No, this is not aspiration pneumonia. It is pulmonary contusion.
Contusion.
Pulmonary contusion is the most common pulmonary opacity in cases of blunt chest trauma. And the pulmonary contusion will appear immediately in the CT scan and may be delayed in the X-ray up to 6 hours. Pulmonary contusion, it changes rapidly, and by follow-up, you got a significant change in the contusion. But the aspiration pneumonia or the fat embolism do not change so rapid, similar to a pulmonary contusion. Then, if you see an immediate or few hours later after the accident and you see an opacity in the lung, consider pulmonary
Pulmonary
contusion,
contusion.
and the follow-up will show significant changes in the emptying. Sometimes you are confronted by this chest X-ray where you feel that this patient is in the intensive care unit, and you look for the endotracheal tube and you see it is optimal in position. Then you have to look very carefully for the ribs, and if you can see these rib fractures, then you know that this patient has subjected for trauma, and the major possibility or diagnostic possibility here is the pulmonary contusion. And if you are asked about the differential diagnosis, there are only two: aspiration pneumonia and the fat embolism. Then,
Dr. Mamdouh,
no.
can I ask about COVID infection superimposed in a patient with trauma? Nowadays, it's problematic. Asking about if it is COVID or contusion.
The
How can
patient with COVID pneumonia and is subjected for trauma, you mean?
Yes.
Then
Yes.
you want to discriminate between COVID opacities and the pulmonary contusion?
Yes.
And actually this is to my mind is somewhat difficult, but if you see the lesions in the plain X-ray, you should favor the possibility of contusion more than the COVID opacities, because the COVID opacities are at the level of ground glass, and they are not clearly seen in the chest X-ray. Also, if you can see fractures of the ribs, and this is in favor of contusion.
Okay.
Then this patient had an opacity on the left side. Do you think that this is rotated X-ray, right lung herniation, left-sided medial pneumothorax, left upper lobe consolidation collapse?
D.
D.
B?
D. D. Left upper
D.
lobe.
Left upper loop consolidation.
This
Of the
one.
left hemidiaphragm.
Okay. This is right, left upper lobe consolidation collapse because of many things. Number one is the silhouette of the cardiac border. There is an opacity with loss of definition of the cardiac border, meaning that this opacity is anteriorly located. And this is confirmed by the lateral view, where you see the major fissure has displaced too much anteriorly behind the sternum. And this is diagnostic of left upper lobe consolidation collapse. And this is the difference between upper lobe and lower lobe consolidation. In the lower lobe consolidation, you see clearly the left cardiac border, meaning that the opacity is located posteriorly. Where here you do not see the cardiac silhouette, meaning that the opacity is located anteriorly. Then this is what we mean by collapse. Consolidation means opacification of the whole lobe with internal air bronchogram. Collapse means loss of volume of the whole lobe, and you can know this by the displacement of the fissure, the crowding of the ribs, and so on. Then consolidation is opacification of the lobe. Collapse is loss of volume of the lobe. The main diagnostic landmark of consolidation is air bronchogram. And the presence of air bronchogram indicates for sure that this is a consolidation in the lung. But if you look here, do you think that this lesion in the upper lobe or in the lower lobe?
In the lower lobe.
Lower loop.
Yes.
Okay, what do you think?
Upper.
Yes, and this is the fissure, and the opacity is totally anterior, and the lower lobe is clear. Okay, what is the difference between collapse and atelectasis?
Atelectasis is small.
Yes, atelectasis is part of a lung or part of a lobe, and atelectasis is just a scar within the lung parenchyma, and the atelectatic band may be thin or thick like this, and the atelectatic band is usually 1 or 2 millimeter, but sometimes it is very thick, as you can see here. Then thick atelectatic band, we call this thick, and thin atelectatic band if it is 2 or 3 millimeter maximum. Then
عفوا دكتور، الفرق بين الاتلكتس والبليورال بلاكس هي نفس المسمى او
لا. No, the pleural plaques is thickening of the pleura, whatever the costal, the diaphragmatic, or the mediastinal pleura. But
الهيري بلاكس
yes,
اقصد.
yes, the hairy plaque is also known as round atelectasis, and this is a different type of atelectasis because atelectatic bands are usually linear, except for this type, which is known as hairy atelectasis or round atelectasis. It looks like a ball or a rounded structure with a speculated margin, and I mentioned that sometimes they may mistake this for bronchogenic carcinoma, but I showed many of the signs that you can use to exclude this possibility. Then this
دكتور لو سمحت الاتلكتيك باند يعني لو انا لقيتها في السي تي اكتبها وبتكون significant يعني بتهم الريفيرد دكتور؟
No, and I have mentioned many times to the clinicians, do not look for any sentence mentioning atelectatic bands. It means nothing. It means an old scar in the lung. But we usually write it in the report to show that we have seen this particular lesion. It does not mean anything, and it's better to avoid writing atelectatic bands, especially in major events. A patient has a bronchogenic carcinoma, then you mention atelectatic bands as well. And patient with COVID-19, then you mention some atelectasis and so on. But usually you avoid, because you know that the clinician may interpret this wrongly and let the patient do further investigations which are useless. Then it is better to avoid this atelectatic band except in the exam, because the examiner usually wants you to see everything in the film. Okay, this is a female patient, 31 years old, with 3 months of hemoptysis, left-sided chest pain, and expectoration. The bus has a cheese-like appearance, no weight loss, no night sweats, no fever. There is a lesion on the left side, and the possibilities are hydatid cyst, round pneumonia, bronchogenic carcinoma, mediastinal teratoma.
Teratoma.
How do you know that this is teratoma?
Bilateral, maybe.
Bronchogenic carcinoma.
Okay, just
According to
wait.
history, exclude the bronchogenic carcinoma. Present of calcium, highly suspect to be teratoma in the mediastinal mass.
But
It's can
bronchogenic
indicate.
carcinoma can calcify, you know?
But the history, exclude the bronchogenic carcinoma, no weight loss, no night sweats.
Okay, but if this is in the lung, you may say that this is a bronchogenic carcinoma even in the presence of calcium. But what makes you favor the possibility of a mediastinal pathology?
Wide relation with the mediastinum.
Okay, but there is an important
Silhouetting sign.
Cardiac
here.
The left cardiac.
The silhouette sign means that this lesion is anteriorly located. Then, if you see, I have mentioned this before, if you see a difference between the site of the lesion in the frontal view and the site of the lesion in the lateral view, then you think of one of two, either mediastinal pathology or pleural pathology. Then this lesion you see in the right lung lower lobe. Actually, if you look here, it will be projected here, somewhat here, but this lesion is projected anteriorly in the mediastinum. Okay, and as you have said that there is gross calcium, and the bronchogenic carcinoma do not show gross calcification in the plain film. It can show calcium in the CT scan. Then you see the density of the lesion is not a true density of a mass. It makes you feel that this lesion contains fat because of the light density of the lesion. Then if you have the CT scan and you see that there are fat and there are calcium and there are some fluids, and the combination of all these three structures is diagnostic of mediastinal teratoma.
Teratoderma.
Yeah. Okay. Then the next case is a male patient, 22 years old, with cough and fever.
Lung abscess.
Okay, and this is true.
Lung abscess.
This is lung abscess, and you got smooth inner margin. You got pneumonic consolidation around the abscess, representing inflammatory changes. It's very important to discriminate between abscess and cavitating bronchogenic carcinoma. The abscess have two phases, the acute one with air fluid level inside, and the chronic one with no air fluid level inside and the smooth inner margin. Then you have to separate the abscess with a smooth inner margin from the irregular margin of the cavitating bronchogenic carcinoma. Then if you look for this patient, there is a cavity with air fluid level. The air fluid level is straight, meaning that this is an abscess with inflammatory reaction around in the lung. Then look for this very important case. This is a male patient, 55 years old, with productive cough, right-sided chest pain, and fever, 20 days. No history of diabetes and or hypertension, and he was chronic smoker and clinically diagnosed as COPD. Then the chest X-ray showed a cavitary lesion with air fluid level and inflammatory reaction around the lesion, highly suggestive of an abscess. Then the patient had a bronchoscopic aspiration of the lesion, and this is the follow-up chest X-ray. After aspiration, there is some regression of the cavity with still the inflammatory changes around the abscess. Then after few days, the cavity has regained and it's more sizable. And this is the CT scan performed on discharge of the patient before this follow-up. And you see the thick wall and the irregularity of the inner margin. But the cavity has been filled once more with pus, and the, as, the pus was aspirated once more, and after that they had a biopsy from the wall of the lesion which showed the presence of squamous cell carcinoma. Then it is very important to look carefully for the inner margin of the lesion. And you know that the cavitating bronchogenic carcinoma can be secondary infected by bacteria, and it will accumulate pus. And if you are looking for this, you may mistake this for an abscess, but the history of smoking is very, very important in dealing with patients with whatever lung opacity. Then we came to the next case, which is a female, 40 years old, with referred from the local jail with tension pneumothorax. She had a long history of intravenous heroin and cocaine. Then what do you think?
Septic emboli.
Septic emboli. Yes. What is the cause of pneumothorax? Incidental finding?
erosion,
Now, the cause of pneumothorax is common in such cases because of rupture of the one of these cavities into the pleural space will lead to the formation of pneumothorax and also some of the pus in the pleural cavity. Then septic emboli appear in the chest as cavitating pulmonary nodules. They may be associated with pneumothorax or pleural effusion or hydropneumothorax. The most common cause of septic pulmonary emboli is bacterial endocarditis, but there are a lot of other causes, especially for those who are drug addicts. These are the possible causes: endocarditis, drug addiction, alcoholism, skin infection, immune compromise, and infected catheter central venous line may cause this. Septic emboli, whenever they are small, they do not contain cavity. But if they reach the size of 2 centimeters, they start to cavitate. Then, in cases of septic emboli, or septic emboli should be included in the differential diagnosis of cavitating pulmonary nodules. Other diagnostic possibilities include cavitating metastases, Wagner granulomatosis, and rheumatoid nodules. Also, the septic emboli. Then this patient is an intravenous drug abuser with heavy smoker presenting by fever, and you see this 3 nodules in the lung. The CT scan showed the classic appearance of cavitating nodules. Considering the history, you should think of septic pulmonary emboli. And the next case is a 76 years old patient with an incidental finding in the chest X-ray. Then what do you think? This is a
Pericardial
pericardial
cyst.
B.
B.
Neuroprecardial.
It is not cyst in the CT scan.
It's not solid.
It is solid.
And
Anterior mediastinal mass. Anterior
deep.
No.
This is
Anterior mediastinal.
this is an anterior mediastinal mass. The mass is located anteriorly and it has a good contact with the cardiac border, meaning that it is in the mediastinum, not in the lung. If you mistake this for a pulmonary lesion, you consider bronchogenic carcinoma. If it is a mediastinal lesion, then you go for the differential diagnosis of anterior masses, anterior mediastinal masses, which are
Thyroid,
Ortiz.
thymus, teratoma, and lymphoma.
okay. This is not, of course, a thyroid because of the
No.
big distance between the lesion and the neck. Then
And not teratoma.
not
Should be
teratoma
thymus.
because of the absence of fat and calcium.
Should be thymo. Thymo.
Yes, you think of thymoma or lymphoma.
Maybe.
Okay, and this is anterior mediastinal mass. These are the anterior mediastinal mass for T, the thyroid mass, thymic mass, teratodermoid, and terrible lymph nodes or the lymphoma. Actually, the thymoma is located between the aortic arch and the sternum in a particular location, and there are two types, the usual thymoma and the invasive one, which can invade the superior vena cava. Then if you see a mass in the anterior mediastinum, and you know that this is in the anterior mediastinum by the good contact of the lesion with the mediastinal border and the projection of the lesion in the anterior mediastinum in the lateral view, then you think of one of four. And if you are able to exclude sometimes in this case you can, this is not a thyroid mass, it contains a big gross calcification which is not usual for lymphoma, and you can not predict if it contains fat or not. Then the remaining possibility is the thymoma, and the previous lesion was proved by biopsy to be a thymoma. And this is a female patient, 45 years old, with left-sided chest pain and dyspnea.
This is empyema.
Or abscess?
Lung abscess.
I don't think so.
Okay.
And
Yeah. And this is empyema, right?
Empyema,
Because
yes.
the lesion is in the pleural
Longitudinal.
cavity, compressing the underlying lung, which is almost totally collapsed, and there is enhancement of the pleural margin, indicating that is infected. Diagnostic of empyema. The difference between empyema and the abscess, there are many differences. Number one, abscess is usually rounded, empyema is usually elliptical. Number two, the angle between the pleura and the abscess is acute. The angle between empyema and the pleura is obtuse. Number three, the abscess is not surrounded by collapsed lung, but the empyema is usually surrounded by collapsed lung if it is big. Then one of the important imaging tools is ultrasound, especially in cases of empyema. And recently we have seen the ultrasound grading of pleural effusion. which ranges from grade 1 to grade 4. Grade 1 is a simple fluid which anechoic. Grade 2, which is a fluid contains some echoes but no internal septations. Grade 3, there are incomplete internal septations. Grade 4, there are thick, complete internal septations with adjacent soft tissues. This grading is very important whenever you are going to treat this emboyema by intervention. If you got this appearance with incomplete septation, you can insert a tube, a drainage tube, percutaneously into the lesion. It will evacuate it totally. But in such a condition, the septations are fibrous, and you cannot pass the tube between the fibrous septa, and only the tube will drain few drops of pus and stop draining after that. Then this lesion needs treatment by endoscope with cutting of the fibrous bands and release of the lung. So ultrasound is the only way. It is more sensitive than CT and MRI in detection of internal septations within the emboyema. And this is an example. This is CT of an emboyema with underlying lung collapse, and this is the ultrasound of the same case. And you can see how many septations within the lesion which are not seen totally by the CT scan. And this is a male patient, 75 years old, with known gastric malignancy.
pulmonary deposit.
lymphangitis carcinomatosis.
Yes, but
Yes,
lymphangitis
lymphangitis.
carcinomatosis. I have mentioned that whenever you see interstitial lung opacities in a patient known to have a primary malignancy, then you should think of lymphangitis carcinomatosis. You know that the lecture of diffuse lung disease contains a lot of the lesions, and actually the recent change in this lecture will include the ground glass pattern. It is also included in the previous lecture. Then interstitial opacities differential diagnosis include usual interstitial pneumonia or pulmonary fibrosis, non-specific interstitial pneumonia, pulmonary edema, fibrosis, collagen vascular disease, drug-induced, radiation-induced. And if the patient is known to have a primary malignancy, then you think of strandy opacities or strandy nodular opacities in the lung as metastatic deposits or lymphangitis carcinomatosis. Then this is a pregnant lady with bronchial asthma presented to the emergency room with cough and shortening of breath. On the day of admission, she coughed large amount of yellowish watery material.
Hydatid cyst.
Yes,
Hydatid
multiple hydatid cysts. Two are intact and one is ruptured, and this is the cause of the patient complaint. And you see the fluid level in the hydatid cyst with the characteristic wavy appearance, diagnostic of ruptured hydatid cyst, and these are two other intact cysts. There are a lot of signs describing the hydatid cyst everywhere in the body. And these signs are summarized in this figure. The spherical cyst with no other features, just a simple cyst containing fluid, or a meniscus sign, which means you got air in the wall of the cyst, which is very characteristic, and the water lily sign, where you got a wavy appearance of the surface of the fluid level, and the serpent sign, where you got floating shadows inside the cyst, and this is known as the compo sign, where you got fluid level and some linear opacities, and this is the rising sun sign, also one of the signs of hydatid cyst. This is the appearance of a simple cyst, and this is the floating sign. You see the endocyst is floating within the cavity of the cyst, and this is another example. And you see the crumpling of the endocyst, and this is a very big hydatid cyst occupying the right hemithorax, compressing the heart to the left side with too many daughter cysts inside. This is one of the most classic appearances of hydatid cyst in the body. And this is the halo sign, where you see air in the wall of the lesion. This is very important. If you see this, you diagnose this as metastasis, you did a very big mistake. Then you should look carefully for the masses in the lung. If you see air in the wall, which is known as the halo sign or the meniscus sign, which is one of the pathognomonic features of hydatid cyst.
Doctor, this chest X-ray needed CT scan?
Usually you proceed for a CT scan, but in the exam, for example, you have to say the diagnosis before you recommend the other imaging modality. Okay, this is a female patient 32 years old.
دكتور معلش
نعم.
المنسكس ساين دي بالشبه الفانجل بول اللي بتحصل في اللنج
No,
كافيتي.
the fungal ball, there is some air that is larger than this, and the ball is a little bit smaller than this, but this is air in the wall of the lesion. And you see, sometimes, actually, this is one of the old cases in my archive, but in the current days I didn't see a similar case. This is quite different from the fungal ball. And this is a female patient, 32 years old, with the chest x-ray. She had the slowly progressive lump on the neck with shortness of breath, no fever, no weight loss, or recent illness. This is a normal chest x-ray, sarcoid, lymphoma, reactive lymphadenopathy, cat scratch disease, metastatic.
Sarcoid.
Yes.
Sarcoid.
Yes, this is the
Sarcoid.
classic history, classic patient, and the classic chest x-ray for sarcoid. Bilateral symmetrical enlargement of the hilar shadows due to lymphadenopathy. There are stages of sarcoid. The stage 0, normal chest x-ray. It's stage 1, only mediastinal lymphadenopathy without lung changes. Stage 2, lymph nodes and lung changes. Stage 3, lung changes without lymph nodes. Stage 4 is pulmonary fibrosis, similar to any case of pulmonary fibrosis. This is known as end-stage lung or end-stage sarcoid disease. Then stage 1, you got lymph.
دكتور لو سمحت
Yes,
is this case stage 1
yes, this one.
الفيلم اللي قبل
This one,
ايوه
yes, and this is the stage 1 sarcoid. Okay, then this is also stage 1. You got bilateral symmetrical enlargement of the hilar shadows with almost clear lung fields, and this is stage 2. You see enlargement of the hilar shadows with reticulonodular opacities in the lung fields, and this is stage 3, where you got opacities in the lung without mediastinal lymphadenopathy. And here you see that the lymph nodes are very small and they are totally calcified. And this is one of the classic appearances of sarcoid nodes. And this is the lung changes. You see the reticular opacities and some nodules in the lymphatic distribution, and the lymph nodes are seen calcified. They are not clearly apparent in the plain film. And stage 4 sarcoid is lung fibrosis with the full-blown picture of fibrosis, the presence of honeycombing, the presence of traction bronchiectasis, and so on. Then, how can you know that this is stage 4 sarcoid? By the history and by the previous terms. But if you do not know anything about the patient and you say that this is usual interstitial pneumonia with the full-blown picture of pulmonary fibrosis. And this patient is 54 years old with dry cough and breathlessness on exertion of 6 months. He was not a smoker and had no previous history of TB. He had worked in a stone quarry for 20 years and had no comorbidities.
Progressive massive fibrosis.
أي
Yes, this is progressive massive fibrosis, two big, almost symmetrical masses in the upper part of the chest on either side of the mediastinum, positive history and classic X-ray appearance. The progressive massive fibrosis is one of the complications of pneumoconiosis with the accumulation of the nodules to form big masses in the upper part of the chest on either side of the mediastinum. And the history is classic, and also the chest X-ray and the CT scan is also classic. You got two big masses with internal calcification. They may show some irregularities of the outline, and you may got some enlargement of the mediastinal lymph nodes, which may contain calcium.
Doctor, can be unilateral?
Actually, if it is unilateral, it will be mistaken for the bronchogenic carcinoma.
Bronchogenic carcinoma,
But
yes.
you should be careful about the history. The history is very important, and actually, many times we are not able to have an accurate history from the patient. And also, if you are in the exam, they do not usually provide the history, thinking that if they tell you about the history, you will know the right answer very rapid. Okay, no problem. This patient is 25 years old with recurrent chest infection and hemoptysis. She had chronic cough and expectorate copious quantities of sputum, frequently blood stained and containing mucus plugs.
Cystic fibrosis.
cystic bronchiectasis.
Cystic
Interstitial
bronchitis.
fibrosis.
Okay, cystic
Interstitial.
fibrosis is the right diagnosis, and this is an autosomal genetic defect where it affects the chloride transport across the membranes, resulting in viscid mucus. And the old name of this disease is mucoviscidosis, which will result in accumulation of viscid mucus in the GI and also in the chest. This will result in obstruction of the bronchi, inflammation of the wall, bronchiectasis, and the mucus plugging. Then the symptoms of cystic fibrosis include recurrent chest infection, wheezes and dyspnea, bronchiectasis, failure to thrive, jaundice, diarrhea, and constipation. There are the two main sites for cystic fibrosis are the GI and the chest. Then in the chest you got bronchiectasis from inflammation of the bronchial wall, and you got the gloved fingers due to mucus plugging in the bronchi, and very frequently you got pneumothorax. And pneumothorax is one of the criteria of this particular disease. Then if you have the CT scan, you see bronchiectatic changes and you see the bronchi which are plugged by mucus, and this image is almost characteristic of cystic fibrosis. Another appearance by the plain film and the CT scan, you see the similar findings. Sometimes in the chest X-ray, you are not able to reach the diagnosis. But all what you can say for this chest X-ray that you are dealing with what looks like a diffuse lung disease, and this lung disease is in the form of interstitial pulmonary opacities. And if you are asked about the differential diagnosis, and you need the help of CT, then if you have the CT and you see the bronchoectatic changes and you see the mucus plugging, then you can easily reach the diagnosis of cystic fibrosis, especially if you know that the patient had meconium ileus and there is an intimate relation between both conditions. Another example, and you see the bronchoectatic changes, and also you see the mucus plugging. Then this patient had a chronic cough and incidental eosinophilia. And I didn't give any choices for this case. I don't know why, but you may answer the question if you can.
Acute
Chronic eosinophilic pneumonitis.
Acute,
Chronic.
chronic,
Cryptogenic pneumonia.
Aspergillosis, bronchoalveolar aspergillosis.
Yes, if you know that there is eosinophilia, you think of one of the eosinophilic syndromes like the acute eosinophilic pneumonia or the chronic eosinophilic pneumonia. Then these are the choices. Do you think that this is TB, hypersensitivity pneumonitis, cryptogenic organizing pneumonia, or viral pneumonia?
Hypersensitivity pneumonitis.
Hypersensitivity.
Hypersensitivity.
Are you sure?
Cryptogenic organizing pneumonia.
Now, hypersensitivity pneumonitis needs a positive history of allergen exposure. And I think that this is the best choice, which is the cryptogenic organizing pneumonia. Then if you see this very classic opacities of cryptogenic organizing pneumonia, which is known as the reversal of halo sign or the atoll sign, then you know that you are dealing with cryptogenic organizing pneumonia. This atoll sign is not common, but it is pathognomonic. Then the disease is of unknown etiology, and previously it was termed as bronchiolitis obliterans organizing pneumonia or the POOP. Then the age of presentation is this one, and there is dyspnea and the productive cough. The radiographic feature, the atoll sign is pathognomonic, but it is seen in only 20% of the cases. And this in the form of the reversed halo sign. You see the halo usually around the lesion, but not inside the lesion. Then this is the halo sign. You see the lesion surrounded by halo, but you see here the lesion with a halo inside. This is known as the atoll site, which is seen in 20% of the cases, but it is highly specific. If you see this appearance, it is highly specific for cryptogenic organizing pneumonia. Also, if you see pneumonic patches that are not responding to antibiotics, and you think of one of two: acute eosinophilic pneumonia or cryptogenic organizing pneumonia, then you go for the blood culture or the bronchial lavage. If you see eosinophilia, you select the first one, acute eosinophilic pneumonia. If you do not see, then you think of cryptogenic organizing pneumonia. And this is the classic appearance, which is not very informative in the plain film and can be mistaken for many other lesions. But in the CT scan, it's quite clear and very apparent for the reverse of the halo sign. Then this elderly male with chronic dyspnea and impaired pulmonary function, he is heavy smoker.
The UIP.
Yes, and this is usual interstitial pneumonia or the interstitial pulmonary fibrosis with classic appearance. Interstitial opacities, honeycombing, traction bronchiectasis, all the full-blown picture. Usual interstitial pneumonia is the description of idiopathic pulmonary fibrosis if there is no cause for fibrosis. But if there is a pre-existing cause, like sarcoid, like scleroderma, like radiation, then you diagnose this as the sequelae of the previously mentioned disease. But if you see the pulmonary fibrosis without any detectable cause in the history or in the films, then you know that this is usual interstitial pneumonia. And this usual interstitial pneumonia sometimes is called end-stage lung. It does not respond to steroid treatment, and the prognosis is not good. The main diagnostic features are two: the presence of traction bronchiectasis and the presence of honeycombing, together with all the findings seen in diffuse lung disease like ground glass opacities, interstitial septal thickening, and emphysematous pulmonary changes. Honeycombing means that you got cluster of cystic lesions ranging in size between 0.3 to 1 centimeter on the periphery of the lung. They have thick wall and usually subpleural in location. And this is a classic appearance of usual interstitial pneumonia or idiopathic pulmonary fibrosis, with the two main features, the traction bronchiectasis and honeycombing, and also you got ground glass opacities. Then this patient had an advanced prostatic cancer. The chest X-ray before 3 years showed this appearance, and after 3 years showed this appearance.
Lymphangitis
Yes,
carcinomatosis.
and this is lymphangitis carcinomatosa together with pulmonary metastatic nodules. You know that lymphatic metastasis can be also associated with blood-borne metastasis. Both can exist in the same patient, but the presence of interstitial opacities in the presence of a known primary malignancy is diagnostic of lymphangitis carcinomatosa. You do not need to have mediastinal lymphadenopathy, and lymphangitis carcinomatosa can occur without mediastinal lymph nodes. And sometimes it can be associated with hematogenous metastasis in the form of pulmonary nodules. And if this is the sequelae of bronchogenic carcinoma, you may see the bronchogenic carcinoma in the same film. And it is essential to know that the patient had a primary malignancy, whatever this malignancy, esophageal, gastric, prostatic, whatever. Then you see these lesions, then you think of lymphangitis carcinomatosis. And this is another example of a female patient with breast cancer showing the classic appearance of lymphangitis carcinomatosa in the form of interstitial opacities with beaded appearance. Then this is one of the pathognomonic features. Then this patient is 20 years old with an acute near drowning incident presented by severe respiratory distress, cough, fever, and headache. What do you think?
Acute respiratory distress.
This is RDS, where you got extensive pulmonary opacities. In the first, they represent edema. Later on, they present consolidation. And this is a ARDS, or acute respiratory distress. It is a form of permeability lung edema and diffuse alveolar damage. The changes can occur at any age, also in the pediatric and in the neonates. Then you got extensive opacities in the lung. At first, these opacities represent pulmonary edema. Later on, they represent consolidation. And the causes of these acute respiratory distress can be remembered by this abbreviation: not cardiac. Near drowning, oxygen therapy, blood transfusion, neurogenic pulmonary edema, allergic alveolitis, renal failure, drugs, inhaled toxins, altitude, and pulmonary contusion. Then there may be a delay of onset in the X-ray findings up to 12 hours. Between 12 and 24 hours, you got alveolar infiltrates. Within 2 days, you got massive space consolidation. Then because of the patient is on the ventilation, there may be some clearance of the opacities, not because of the clearance of the disease, but because of the ventilation. Then if the condition persists, the patient may develop a superimposed pneumonia or may pass later on into lung fibrosis. The continuous positive airway pressure is known as CPAP, and this CPAP may be complicated by the development of pneumothorax, pneumomediastinum, and pulmonary interstitial emphysema. This patient, 33 years old with dyspnea, and there is a big mass in the chest, and the mass
Teratoma.
Teratoma.
Yes, this is mediastinal teratoma because of the fat. And you see here, this is not air, of course. If it is air, it will appear in the plain film. And this is fat and the fluid and the solid. But there is no calcium. Then the presence of fat and the fluid is enough for the diagnosis of teratoma. If calcium is present, well and good. If not, there should be two of these three, but fat is essential. There should be fat in the mass to diagnose teratoma. Like this one, there is an anterior mediastinal mass with fat hypodensities, dense calcification, and soft tissue component, classic appearance of cystic teratoma. Another example, the mass in the chest, and the CT scan showed the presence of fat and the calcium and the soft tissues, diagnostic of teratoma. And in the chest X-ray, you cannot say for sure that this is a mediastinal mass, but if you look carefully here and you see the mass is in contact with the mediastinum, compressing and displacing the heart, contains some foci of fat together with calcification and the fluid densities, then you reach the diagnosis of teratoma. هذا وبالله التوفيق.